Thank you, everyone, for joining this International Home Dialysis Consortium webinar. This International Home Dialysis Consortium is a joint initiative of the International Society of Peritoneal Dialysis and the International Society of Nephrology, but subsequently, like group that gathers more and more fellow travelers as it goes along. We have been joined by a number of other societies, regional societies, national societies, etc., and it's become quite a movement. So this webinar is going to present to you the current journey from its first meeting to where we are today, which is an important milestone of the development of the International Home Dialysis Consortium Manifesto. My name is Vivek Jha. I am one of the co-chairs of the steering committee of ISHD Consortium, along with Professor Edwina Brown of Imperial College London, the immediate past president of the International Society of Peritoneal Dialysis, who will be the first speaker. And then, of course, we'll have other speakers also who are listed here. Dr. Christopher Chan from Canada, Dr. Abdou Niang from Senegal, and Dr. Peter Rutherford from UK, and Dr. Sandip Mitra from the UK as well. So can I invite you, Edwina, first to tell us about the ISHD?
Thank you very much, Vivek. Can we have the next slide? So as has already been said by Vivek, the International Home Dialysis Consortium is a joint venture of the ISN and ISPD, which is the aims are to bring various stakeholders together regionally and globally to drive home dialysis in a structured way. And the mission is to promote equity and increase access to home dialysis globally in both high and lower income countries. Next slide. We've already published in Kidney International Reports in 23 an introduction to the Home Dialysis Consortium. And really just the purpose of showing this is, first of all, to give you the reference, but also to explain that the steering group consists of members from the ISPD and ISN, but also from the International Society of Hemodialysis, the Asian Pacific Society, the Pediatric Society, South American and African societies. And we've also been joined, since we wrote this paper, by EuroPD. And we are also in the position of having industry partners. Baxter and Fresenus are represented by their global medical directors on the steering committee, because we felt very strongly that we can't, as physicians, we can't expand access to home dialysis without industry. And obviously industry can't expand their business without the input of physicians and nurses. Next slide. So we're all aware of the challenges to home dialysis growth, and I'm not going to go into details. They've been published in many places. There was the KDIGO Home Dialysis Controversies Conference, which really brought to the fore all the various challenges to home dialysis. The mission of the IHDC, next slide, is to actually identify tools that can be used for implementation to expand access to home dialysis. And we had our first meeting and launch at the World Congress of Nephrology in Argentina in April. We had 4 work streams: empowering people needing dialysis, nephrology workforce education, developing workforce and resources, and then one focusing on the politics, integrating care and payment policies. And the industry partners who are part of this were Baxter Healthcare, Fresenus Medical Care, and Medtronic. Next slide. Subsequent to that meeting, I'm not going to go through the output from that meeting because the talks following mine are going to be summaries of the outputs from the Buenos Aires meeting. We have produced a manifesto jointly with the ISN and ISPD and is available on a microsite on the ISN website. And I'll just read out what we said in that, which is by engaging with national and regional nephrology societies, patient organizations, researchers, commercial partners, that we will identify policies and funding, and we want to leverage ideas, efforts, and advocacy worldwide with the ultimate goal of bringing the benefits of home dialysis to more patients in need. Next slide. We also went on to say that obviously all forms of kidney replacement therapy are potentially life-saving, and as a key priority, kidney replacement therapy should be available for everybody, but access to home dialysis has lots of advantages. And the purpose of this manifesto is to engage different societies globally to sign up and therefore get involved with the conversation. So this is a public declaration advocating the promotion of home dialysis globally. Next slide. And again, each group brought forward some key points which are in the manifesto. Next slide. Developing workforce and resources. And the next slide. Developing workforce and resources, the policies. So we are inviting individual societies to sign up to this, and we've already got signatures and commitments from some in South Africa, Georgia, UK, AFRAN, just to mention a few. Next slide. So now what we're going to do is hear from each of the groups what were the key points that went into the manifesto that emerged from the Buenos Aires meeting, and following that we will have a general discussion. So over to you, Chris.
Thank you again, Edwina, as well as Vivek, for organizing the International Home Dialysis Consortium. I have the privilege of serving on Group 1 as a co-chair. I also want to make sure that I mention that this is really absolutely a group effort. My other co-chair is Dr. Brigitte Schiller, and we were tasked to really think about and also articulate the need for patient empowerment within the entire organization of home dialysis. Next slide. We know that currently there are significant systemic barriers, and understanding the adoption obstacles is really key to enhancing home dialysis uptake. We know that home dialysis adoption is hindered by a lack of awareness, and this actually is not only a patient barrier, but in fact actually a systemic barrier. I think it is important that awareness is noted, and also systemic inequities is also attacked widely, so that we know, and as mentioned by Edwina, that ultimately it has to really come from a manifesto, really driving the notion that education is in fact a right. Next slide. We know that education is needed both for patients as well as caregivers, but more importantly, also for providers. Patients need to know and be aware of how they should opt in or opt out of different modalities in kidney replacement therapy, and only informed decision-making can really drive the whole notion of home dialysis for all. I also think that caregivers is a crucial and vital part of patients' education. by empowering caregivers with knowledge also enhances their ability to support patients to make their informed decisions. Clearly, home dialysis practice is very heterogeneous across the globe. And in part, this may have to do with knowledge awareness and also practice of home dialysis across the world. And healthcare providers need to be equipped with both comprehensive CKD education and also how to deliver quality care in home dialysis so that we can both address misconceptions as well as promoting home dialysis options. Next slide. As mentioned, in part, our group as well as others have advocated during our launch in WCN a manifesto. The manifesto really serves multiple fold. In our work group, we feel strongly that education is a right, that we feel that there is a commitment to education so that we strive for universal CKD education across all demographics. Our focus is to overcome disparities that may be tied to resources, that may be tied to policies or economics. We also feel very strongly that this declaration emphasizes the right to care and knowledge awareness, that home dialysis should be accessible, and that education is the cornerstone of empowering patients throughout their entire journey in kidney replacement therapy. Next slide. We also know that we need to engage many stakeholders, and the key stakeholders are listed here in this table. Some of them have already been noted both by Vivek and Edwina. We know that these roles are important, and in no priorities, we have ranked them here in this table, and then also address the impact of having enhanced knowledge and better informed decisions so that we can make the appropriate choice for the right person at the right time in the right place. Next. Through our own surveys, as well as looking at the environmental scan, we know that equity in access is different around the world. We know that in some parts, the availability of home dialysis is challenging. We also know that resources may be limited and that there are systemic disparities across the world because home dialysis may not even be aware by either the providers or the patients, and also may be difficult from an economic policies. Some of them will be addressed in the later part of the talks today, and then we also welcome your thoughts about how to help to overcome these barriers during our general discussions. Next. Therefore, in my 5 minutes or so, I hope that we were able to put out some of the most significant points during our discussion at the launch of our meeting. We know that we need to do more engagement strategies. We need to focus on expanding CKD education universally. We understand that strategies to leverage technology and also community programs may be also an important critical component to bridge these gaps in knowledge and support. Mentorship from referring centers to also other satellite hubs across the world may be an important lever to this strategy. Ultimately, we hope that by improving education access, we can enhance patient and providers' engagement through a tailored education so that we can build partnership with organizations to develop a more encompassing and also universal home dialysis strategy across both local needs and also other countries and context. Thank you for your attention, and I look forward to addressing some of your questions and comments later on. I'll pass it to the next speaker.
Thanks very much, Chris. Can I now invite you, Abdou, to talk about healthcare worker education?
Thank you, Vivek. Our group was working on the nephrology workforce education
Sorry,
slide.
Abdou, sorry to interrupt, but can you also introduce yourself? I should have done that, but you are already speaking. So can you introduce yourself to the
Okay,
audience?
okay. Thank you. I'm Abdou Niang. I'm the head of the nephrology department in Cheikh Anta Diop University of Dakar, and the president of African Society of Nephrology and the Senegalese Society of Nephrology. Thank you, Miguel, and the organizers. Our group was working on the nephrology workforce education. Next slide, please. And the objective of our group was to develop basic educational material for all levels of kidney health professionals, and to identify ways to encourage and engage professionals to translate to practice what they have learned, and definitely to discuss innovative ways to deliver educational amongst practitioners. Next slide. And the plan for the last meeting of WCN was to study how to target PD education at all levels of workforce, medical, surgical, and nursing. Next. And during this meeting, the next meeting in Delhi, this expert meeting will focus on the South Asia situation, especially looking at finding solution for the problem in India. Next slide. And the potential benefit for reference centers was funding for training of nurse and doctors, recognition, and the workforce sharing between different centers. Next. We work on different criteria for centers of references, and to determine the minimum numbers of patients initiated on PD, the availability of clinical expertise, and also the resources for training. And it will be very important to have some years of experience and to note the KPI within the benchmark and the region-wide centers. Next slide. And about the manifesto, we work on the reference center criteria, the core curriculum, and the training platform for training advanced practice nurses, and to increase the number of PD patients, more professionals competent in starting the therapy, and percutaneous catheter insertion. Next slide. And here we summarize the group 2 discussion in our last meeting in Dubai. And we emphasize on the local participation reported that doctor training is well structured than the nurse training, which is carried out primarily by companies with specific courses. And we highlight also the gap on the training of pediatric nephrologists and services in rural areas. The group suggested partnering with local societies to train new professionals and to identify key nursing and medical people who can be champions of spreading this therapy, and together with local societies to create an action plan for education, the workforce in the area. Next slide. And the PD training of for the healthcare personnel will target the nurse and doctors, primary care physician, and nephrologists. Next. And to train the trainer, we have to structure training program and to have a comprehensive training program to determine the component in training, principle, and concept, and to use the technology in managing PD and protocols guideline to train these trainers. Next. And for this training, we need a core course for all groups and specific extended courses for each group of personnel. Next. And the training modalities for doctors and nurses will base on structured comprehensive training program, on-site skill training with video, high fidelity mannequin for simulation training, free teaching materials in ISPD, and it will include PD component and mentor-mentee program. Next. And for example, for percutaneous insertion of PD catheter, we have to train nephrologists and nurse specialists to insert catheter percutaneously. And this will increase the number of patients initiated on PD. Next. And finally, region-specific consideration will depend on availability of nephrologists and government policies. Next. And the advocacy for nurses will take in account for advances skill practice and the patient to be included as workforce for training. Next. Thank you for your attention.
Thanks very much, Abdou. Next, it's my pleasure to invite Dr. Peter Rutherford, who represents Baxter International, perhaps soon to be known by another name in the International Home Dialysis Consortium. Prior to being at Baxter, Dr. Rutherford has had long experience in the UK healthcare system, and he has worked with NICE, and where he helped develop guidelines. And for the last many years, he has participated in advocacy and improving care for patients on peritoneal dialysis. So it's my pleasure to invite you now, Peter, to talk about workforce resources and pathways to care for patients on home dialysis.
Thanks so much, Vivek, and thanks everybody for gathering today, and a big thanks to ISN and ISPD for putting on this. Well, it could be early morning, it could be late evening, depends where you are, but we're all here together, and but great to talk about home dialysis, as you've heard from the manifesto of this. What I think, as Edwina put it at the start, a really growing collaboration between different stakeholders, and I've been really honoured to be taking part in Group 3, along with our co-chair Magdalena Madero, and we're focusing on the doing of things, the workforce, but the implementation of things into clinical practice. So can I have the next slide, Miguel, please? So the problem statements at the top, many barriers to the growth of home dialysis globally, and variations on a theme across different parts of the world, often driven by income and by healthcare system, and the clinical experience. So not only I know what to do, but I'm experienced in doing it. And then the health system factors of, do I as a nephrologist or as a PD nurse get to see the patients because the system has problems in it? These two things play a major role in the big variation that all of us know about in the use of home dialysis, both between countries, but also within countries. We know that whichever country we're in, there are some large home dialysis clinics and there are some very small. And that's all about potentially the experience of the practitioners working within and the planning, the pathways of care that they are working in. And then, of course, it's always a delight when colleagues want to do new things. And starting a home dialysis program and then growing it is harder than it sounds, a lot harder than it sounds. So another problem for the consortium to face is around how can we support the creation and opening of home dialysis programs across the world with all of the variation that brings, with strong clinical leadership. And I think that's a really important part of home dialysis, the clinical leadership, and a trained workforce. And as you've heard from Abdou, that training of the workforce is a key part of of the consortium's work with Group 2. And then Chris already has talked about the importance of the patient education as being the other key partner in this. So we've tried to move to action. We've tried to, okay, what can we do in practice from the consortium that will help along these lines? So these are our two aims of work and delivering things. First, we want to support the implementation of pathways of care, which would allow informed choice and then the starting of the patient on home dialysis. So the pathway of moving the patient from the point of progressive CKD to actually getting that training for PD or the training for home HD. And then the second one is the creation of an online toolkit of resources to help units start and grow. And then you'll see there's a linkage with the work of Group 2 around the support to give that kind of unit. I'm a big believer that if somebody has thought of something good before, why not think about it again rather than reinventing the wheel? So when it came to this question of pathways of care, in our Buenos Aires meeting, Rob Quinn brought out, well, why don't we use a pathway that had been created and start to be implemented in Canada? Next slide, please, Miguel. So this is what we're aiming to do, is to really drive the implementation of the thinking and then identification of the issues along this pathway to dialysis start. It's the starting dialysis on time, at home, on the right therapy. START. Nice to have a really catchy acronym as well. And we've got the 6 steps, as you can see. The first one being identifying patients. We were talking to doctors in India as preparation for our Delhi meeting recently, and that's clearly a challenge. Many unplanned start patients. Well, how can we identify the patient who needs then the next step, the assessment for the need for dialysis start, and then to move on to the eligibility. What are the issues that make home dialysis easier? What are the issues that need some work to overcome? Then the offer, the decision-making, the shared decision-making, the offer of starting of PD, starting of home HD is a critical next step as well. And then making the choice, and I think many of us would agree, writing the choice down, not in a tablet of stone, because things change, but making sure that everybody remembers what the decision was as the patient then progresses to the 6th step, which is the start of home dialysis. And each of these steps, we want to put tools alongside that can help support practitioners across the world take their patients through this pathway. It's simple enough to be generalizable, and we anticipate with tools to support, we can start making a difference. I'm a big believer in the phrase, what gets measured gets done. So this kind of pathway is auditable in a very simple way. We can start counting and capturing how many patients do I identify, how many are assessed, how many are eligible, what are the issues along the pathway. So that's the first piece of work really for 2025. The next piece of work is described on the next slide, please, Miguel. And that's this issue of an online toolkit. Can we, and again, not reinventing wheels, there are many, many great material out there. Can we identify that, pull that together to form a program building module, which is built up of the various stakeholders on the top of this figure, be it the IHDC members, as Edwina said at the start, the nephrology societies in everybody's country. We as industry partners, we clearly have a role. But Abdou mentioned the Centre of Excellence. Can we team up the new starting unit with the more proficient unit to support as well, so that people aren't on their own? And both ISN and ISPD have got a track record of doing this. And then the model, in the content of the online portal would be down as below. All of those materials, all of those resources that if you have them, it's great. If you don't have them, it's a problem. Let's pull them together in one place, make them available alongside that human touch of the Centre of Excellence and Support, that this network of home dialysis experts and interested colleagues are coming together to form will really move this forward. So that's the work of Group 3, and we're delighted it's only a month away. We'll be in Delhi and we'll be talking about how particularly the pathway approach can work in a very, well, every country is unique. So let's say it, a unique country as large as India, exciting to think how we can support home dialysis growth. So thanks, Vivek, and I'll pass on to Sandip.
Great, thanks, Peter. And as you said, we are now welcoming Dr. Sandip Mitra from Manchester, Royal Manchester Infirmary, and consultant nephrologist at the University of Manchester, senior lecturer there. He's academic research interest in dialysis medicine and blood purification techniques, and he works with biomaterials and devices for extracorporeal fluid sensing and transport, etc. And he has been an innovation lead. He has had an innovation lead role in promoting patient-centered technological solutions for unmet clinical needs in healthcare. And what he's going to talk about really is sometimes the crux of the issue, the financial and funding issues. And this is also relevant that we have a question in the Q&A box here. How do you support implementation of home dialysis, both home hemo and PD, in low-middle income countries where in-center hemodialysis is less expensive and generates more profit for doctors and centers? I'm not sure that Dr. Mitra is going to immediately answer this question, but that's something for us to continue to think about. But over to you, Dr. Mitra, for discussing the politics of it, integrating care and payment policies.
Thank you very much, Vivek. Vivek, can you hear me all right?
Yes, we can.
Thank you. And thanks for putting up the first slide. So you can see that the group 4, following on from what you've heard from the other groups, are also given a clear sort of agenda to focus on the policy initiatives and enable the infrastructure and the systems to deliver what's being planned in the other work groups. This is the manifesto that has evolved from several meetings in group 4. And they're obvious ones, but this is really our sort of template to develop action plans and sustainable strategies around it. So it's really about starting with engaging policymakers, payers, and the dialysis industry, very important stakeholders to support the growth of home dialysis, but also adapting actions and taking steps to the local needs and the realities and the economic systems themselves. Professional societies and advocacy groups will play a very important role in driving the policy initiatives and sort of helping develop this global framework. We also want to create policy briefs to support advocacy efforts, and as Peter's mentioned, to really give weightage and support through these policy efforts to tools and audit processes that are being developed as part of the QI in measuring and assessing the quality of a home dialysis program. A big issue that has been discussed in our group and will be further delved into is reimbursement schemes that add value, that make dialysis more sustainable, but deliverable in the contextualized setting of each country, and thereby look at reimbursement models for home dialysis. But most importantly, study and hopefully enable and remove some of the disincentives that are at play, and there are many that we've heard from speaking to different clinicians across the globe, certainly discussing with colleagues in India in a recent meeting we've had. The next slide, please. So stakeholders are very important partner in this group. So, and within the group itself, apart from clinicians from different continents and countries, we also have industry representation. But the stakeholder group is much wider. It involves patients and caregivers, the policymakers, the payers, along with societies and the industry, of course. So we want to touch these stakeholders with equal emphasis to deal with some of the issues I've highlighted that each stakeholder would be responsible and would help us deliver. For example, the cost effectiveness question needs to be dealt with. We are studying different cost effectiveness studies that have been done in various countries and looking at what applies to which part of the continents. And that's part of the exercise going on at the moment. But all these stakeholders play a very important role. And I think, as we discussed in our previous meeting, we may have to step outside our group to really have meaningful engagement to make this actions from this working group come to fruition. Next slide. Cost effectiveness and reimbursement models is a very sort of key pillar in this work group. And we've been studying how the current models can be rethought and redesigned, perhaps, at a policy level. So looking at accessibility and affordability for home dialysis, reimbursement covering not just products and consumables, but the whole therapy as a whole, looking at the full disease cost of end-stage kidney disease being treated with dialysis. So we are going to be examining these models, but I'm sure we'll come up with slight variations depending on which part of the world we are studying this in. The next slide is about reimbursement models. Can I have the next slide, please? So with reimbursements, we are looking at coverage and payment schemes. The national schemes that exist, certainly there's one in India. We've been examining that, and we'll be discussing it at the WCN in a month's time. Redesigning patient schemes that do not disincentivize any stakeholder within the dialysis framework. And of course, a key part would be to make sure that patients don't feel burdened with the therapy. Physical burden has to be mitigated against, mental burden, and of course, financial burden. This has to be a key focus of any policy reimbursement scheme. And the next slide delves further into some of these considerations. At a policy level, we want to look at supply chains. We've heard a lot about, in every meeting we've had, around issues around supply chains. And there's perhaps a disconnect or even a lack of understanding of where these supply chain issues lie, depending on which lens you put on it. So we are getting a real good insight into these issues that we want to mitigate against to avoid therapy interruption. That can be quite fatal to a home program, in my experience. And looking at in-center capacity, how dialysis quality can actually be benefiting in-center patients by growing a home dialysis program. My home dialysis program actually benefits my in-center patients because I can give them much higher quality of dialysis without the constraints that otherwise exist in in-center models alone. And assessing the value proposition that speaks to the payers, the funders, but also the users, the consumers, and the practitioners. The next slide is really looking at incentivization. This is a debatable topic, and clearly there's various models of incentivization that has been tried in different countries. So in UK itself, there was a financial incentive scheme that was launched a few years ago for a 3-year running program. And some success has been achieved. But what we have also learned from experiences in Canada and in the UK, that financial incentives alone would not be sufficient to sustain adoption and growth. And that one other missing element, even if we get the finances right, is the culture or the mindset shift that is required to change the paradigm in dialysis provision. The next slide is a paper that was published when we did our work globally. We got together to write this paper that summarized some of the need across the world, doesn't matter which part of the world we're in, to try and change culture shift. So culture shift in home dialysis is required. And you can see some of the action points that have come out from those initiatives that are listed here. So combining the incentivization or removing disincentives, most importantly, with a culture shift can actually sustain a home dialysis program. We're going to focus on both with equal emphasis in the work that will evolve from this group. And next slide. We are also sort of working, we will be working with the other groups. So for example, group 3, where we'll be looking at what are the acceptable standards for delivery of quality care. And in terms of how we can overcome the challenges of delivering, creating the therapy delivered infrastructure for home deliveries and education. So a lot of the work will overlap and must sink in with the other working groups. But you can see the ones that we obviously see as big issues within our working group is resources in terms of supply chains, equipments, home environments, and communication of between the patients, the prescribers, and the system itself. And that is largely unstructured or even lacking in many parts of the world from our speaking to colleagues across in different meetings and in conferences and in the preparatory work that we've done. We also want to develop the dialysis framework that exists. We're looking at all modalities of home therapies, both PD and home HD. The latter is a more complex challenge, and there need to be perhaps more work done in terms of incorporating that within the dialysis framework and requires adaptation perhaps. So we will be updating frameworks to design sort of quality frameworks that can apply to different resource settings, but also address different modalities within the home therapies. And finally, my final slide is about the work that is about to unfold in a month's time when we meet in Delhi. So we are recently decided to focus on 2 or 3 things and start working and influencing on those areas. And you can see the top 3 that comes out: reimbursement models. We have to understand this better and articulate it better to all stakeholders. Support structure seems to be a key unmet need. And there's some difference in understanding of what that means or what that's delivering at the moment at a policy level. And of course, integrated care, that we will work with other working groups. And the call from the group has been to come up with solution-focused strategies. We've heard how the country-specific overview can vary in terms of challenges and key barriers. For example, we were listening to our colleagues from Nepal, a neighboring country from India, that the challenges are quite slightly different, perhaps, magnified in some areas and not others. So we want to be sensitive to the local and contextual need. Sometimes regions can vary too. But then look at the dialysis schemes, reimbursements, and incentives. And in this pillar, we are even contemplating bringing in stakeholders that do not necessarily sit within the current working groups and could be outside the clinical world, could be payers and funders coming into the discussion forum, and how we can drive policies that actually meet those unmet needs for patients and for programs. Support systems. There is a huge gap that we've identified, needs to be addressed. But also developing infrastructure that can just not deliver consumables, but the therapy itself. So hub and spoke model, perhaps we are talking about developing home programs so the physician or the clinicians feel supported. There's enough infrastructure around them to actually make sure the patients are safe and meet their needs, supporting integration and transition between therapies. And finally, identifying and supporting the levers of change at a policy level. We have to focus on that so that some of these earlier sort of working groups and some of the stuff coming out can actually be actioned. I'll stop there. Thank you, Vivek.
Thanks very much, Sandip. And now we have time for some discussion. And we have, of course, the experts here with us. So Edwina, Abdou, Peter, Chris, and of course, Sandip. We have some questions or comments in the Q&A box. And Dr. Vikram Agrawal has offered his view, and he thinks that sustained motivation of the workforce is key. And he advises undertaking education, both online and in person, for nurses, technicians, and caregivers, etc. So thank you, Dr. Agrawal, for that suggestion. And of course, as you said, that's really at top of the agenda of the International Home Dialysis Consortium. And as I said, Dr. Jaraya from Tunisia has already asked a difficult question of how to incentivize or popularize home dialysis in countries where the incentives are aligned in the opposite direction. That really is critical. And I don't think, I'm wondering if any of you has any thoughts about it as to what can we do, and if you have examples of jurisdictions where this kind of challenge has been overcome.
Can I just say something?
Yes, please go ahead, Edwina.
Listening to the presentations and seeing the comments and the wide interest of people from all over the place, clearly a small group like the IHDC is a consortium, and it's really a gathering point for other people's experiences, rather than being able to produce a toolkit or education that's going to be applicable globally. So the first step has been the production of the manifesto.
Mhm.
And that is just a first step to get regional and national societies involved with the concept of the Home Dialysis Consortium and promoting home dialysis. I think the next step will be to get the tools that successful countries are using for education, so that like we can, websites, recommendations, curricula, training, because they're going to be in all different languages, and then amalgamate these so that new countries, new centres can then have a look and see, pick and choose what is going to work for them. And that is a potential way forward. I mean, what we're doing at the moment is linking in with detailed discussions where the WCN or ISPD meetings happen to be. So this year, the discussion will really focus on India and surrounding countries, but predominantly on India, because that's where WCN is. Next year, I can see there's already a question about, can we help Japan? Well, the WCN is in Japan next year, so we will be having a meeting at WCN. And again, that will enable focus on Japan. But that, to cover every single country, that would be slow and laborious. That's just not feasible. So for those of you who are on the webinar, and those of you people who signed up for the webinar but haven't been able to attend but can watch it subsequently on our YouTube channel, we will be emailing people to ask them to send us either stories, websites, etc., that we can then accumulate. I don't know whether anybody in the panel wants to follow up on this.
I think it's really the invitation, if you like. I hope that we can actually also solicit people's help throughout our communications. This is clearly not a job for just one person. This is not a job for one society alone. The demographics and also the practice of home dialysis is very heterogeneous globally. And I think a lot of local context and understanding is needed. Having said that, in our group, in terms of empowerment, I think knowledge is very important as well. The awareness of home dialysis really is the first step, be that the providers and or the patients and caregivers. I think if the patients aren't even aware of home dialysis, they will never pick it. It doesn't really matter what the incentives may be aligned or not aligned. And different jurisdiction has changed the alignment of incentives to actually encourage home dialysis in different parts of the world. And that has changed adoption, obviously. But I think education is probably the critical step universally. And I don't think that we can always, I don't think that there is an excess of education. There's always the need for more.
Well said, Chris.
If
Other
I can
thoughts?
just conclude,
Yeah.
Vivek, just a thought that I think just echoing and resonating what's been said already, but where I have seen it succeed is where it's happened, started at the frontline staff, the patients, where the staff and the patient are interacting with each other. So this starts from there. The seed of success is born out where the patients are meeting professionals, both nurses and doctors. So it's quite far removed from where our starting point is. But what we're trying to do is create the environment, create the aids, tools, and support systems that are required for people to feel motivated. I think motivation is probably the right word, because this is not complex. This can be done by current dialysis professionals, but it does require change in mindsets of support systems to be in place. And that's what we envisage to do by understanding the local context, meeting with local teams, and helping bring the stakeholders together. That's as much as I think we can do. But what can happen really make this grow into a successful program is from frontline teams and stuff.
Thanks, Sandip. On my part, what I would request actually, all of you who are leaders of your working groups, as you come together in New Delhi, is to come up with one perhaps low-hanging fruit in each of the working group that can be relatively quickly implemented for some quick win. And as we go around the world, of course, doing this for each country is difficult, but in 2-3 years, we'll have a bunch of these which will potentially be valuable for us to present as offer as solutions which others can use as well, as even as we grow the list of these resources on the ISHD website and microsite. IHDC rather.
A question to you, Vivek, if I could ask one, is that, how do we monitor progress? So is there a global registry where we can tap into or pull from other registries some of the data going through so that we can actually start seeing the effects of, as you say, the low-hanging fruits or systems that are coming into play? We just need to be mindful that we are actually not losing track of progress or even lack of it that we are making, so that we are actually on the money.
I'm afraid I don't have a ready-made answer to your question, and maybe other members on the panel can also pitch in. But I think that will be a good problem for us to try and solve, where we are tracking progress, because that is what we are hoping to be able to achieve. Certainly, a perusal of existing registries and the proportion of individuals on various home dialysis modalities in those registries gives us a sense. But whether we are ready to talk about a home dialysis registry or not, I'm not sure. But maybe other colleagues have some other thoughts.
No, I think you're right, Viv. There isn't a global registry, and quite honestly, I don't think that's, for a few reasons, not really feasible. I'm a big believer in locality, in local measurement, and people seeing why measuring things makes things better. And I think Sandip mentioned about the quick wins, and sorry, Vivek, you did, about the quick wins, and I think that's part of it, and part of that has to be data driven around just how many patients do we have starting dialysis. How many are unplanned start? How many of us really know that? We can have a guess. How many of us, when we're asked the question, what's your peritonitis rate, we say, it's okay, it's below the ISPD standard, but we don't give a number. And I think that trying to, we're a data specialty. We're full of numbers. We're surrounded by numbers. And if there are simple ways that we can start and really pick on that measurement. I'm very taken by some of the ISN work around empowering the patient around gathering data as well, and actually using simple ways to gather key measurements which can help us understand, are patients getting that education? Are they transitioning onto home dialysis? And then what are their outcomes? Well, who better to know that they got told about it, started it, and got peritonitis than the patient themselves.
Thanks, Peter. We have just a few minutes. So there is one question from Isabel Ethia from Canada, who's a young nephrologist, part of the emerging leaders cohort of the International Society of Nephrology. And she wants to know, how can we get involved in the consortium itself? So Edwina, what advice do we have for Isabel?
Well, I've already given some ideas. So we need to collect information from individual countries about what is happening in each country and what resources there are. So that's number one. And then we need to review that and somehow or another summarize it and create a website that people can then use to find resources for themselves. So that's a big piece of work. So if there are people out there who want to help, you are very welcome. Looking at the other questions that have emerged, There's one about, the issue of where the finances in favorable of in-center hemo because it develops profit. That's something that will be addressed, it sounds like, by Group 4, the one that Sandip is chairing in Delhi. That's a really important issue in India. There's a patient group that's offered some support that's really helpful, and we need to really think about how do we engage with patient groups. In some countries, these are very powerful, like in the UK and in the US, but in other countries, patients don't have a voice, and we need to think about how we engage with them. There's experience that people have put in, from their own centres. And then there's a comment from Kamal Shah, who's in Australia but has got Indian links, about how in India home hemo is done in people's homes with a technician actually delivering the dialysis. And this is a model that's not just in India, it's also in the Middle East. And yes, we are aware of it. And we support all sorts of home dialysis. And home dialysis will be delivered in different ways in different countries. And that is something that we need to explore. And then there's a really interesting comment about people in really remote areas, Jammu and Kashmir. And we do need to think about how do we support people in remote regions of the world where really home dialysis is going to be much more patient friendly than having to use bad roads, snow, disasters, etc., to get to a central unit. And that is something that, yes, we need to think about. So we've got lots of things. Thanks for everybody's input. You will all be getting a follow-up email about the manifesto and how you can help the consortium. And this is just the first of many discussions.
Thanks, Edwina. Just a minor correction. Kamal Shah is not, you're perhaps mistaking him for Kamal Sood. Kamal Shah
yeah, I am.
is a
Sorry,
patient
yeah.
himself. He's on home dialysis. He's been on dialysis for the last 25 years. He's done PD and currently he's on home hemodialysis. And so he has a lot of experience. But I join Edwina in thanking everyone for their interest in this topic. We see a lot of participants who are here, and the fact that you have put in your comments, and we are hoping that many of you, at least those of you who are from within the region, will also join us at the World Congress of Nephrology in less than a month's time in New Delhi. So thanks, everybody. Bye.
Thanks a lot. Bye-bye. Bye-bye.